Hello, my name is Dr. Amanda Witt. I am a physical medicine and rehab doc, and I work in the neurology department here at UMC. We're going to have a couple of lectures about traumatic brain injury. This one's going to be how we manage the long-term sequelae of brain injuries. So this will be a follow-up to Dr. Washington's introductions, and then we'll talk more about concussions specifically in the next one. So we're going to talk about the deficits common after traumatic brain injury, cognitive, language, motor, and then link these back to the neuroanatomy. We're going to work on the medical complications that are common after traumatic brain injury, so you can know some of the management and screening and prevention that is important with these patients. And then we're going to learn a little bit of how to take care of them in a summary. We're also going to look at a few risk factors for severe injury. Has a hemiplegic gait where the arm stays flexed up and the leg tends to stay extended down. This next pattern I tend to see more in anoxic injuries. This can also look like a central cord syndrome where the person's arms are weak and possibly spastic, but their legs aren't as affected, and this is because in anoxic injuries you have a watershed distribution pattern, and so the areas that are between the anterior cerebral artery and the middle cerebral artery tend to get the most hit, and that tends to be upper extremity corticospinal tract. And so these patients look like they're in the barrel, the legs look okay, but the arms are dysfunctional. In fact, we had a patient that kind of looked like a little T-Rex because her arms were really flexed and tight, and she had trouble using them. But she had a stiff gait. It wasn't normal. She had some balance issues, but her legs were doing much better. She did improve with this, but this is not uncommon. Dystonia is another type of increased tone. So if you think about increased muscle tone, you can have spasticity that tends to be in one direction. Like, look at this fella. He's got everything flexed in the arm, everything extended in the leg. And so you don't have like the bicep and the tricep tight at the same time, for example. Not with classic spasticity. You can, of course, have a mixed pattern. Dystonia is where you have the agonist and antagonist muscles that are both tight, and so instead of just having a flex up or an extension out in one direction, you're stiff all over. So this obviously can be like a Parkinson's patient who doesn't have enough dopamine and can be really stiff, but it can also be with somebody who's had an injury that has affected the basal ganglia or the midbrain structures. They get kind of an all-over stiffness. This can also be a type of athetoid pattern when they almost have writhing movements, all of which is associated with a basal ganglia type injury. This man, for example, has dystonia. He's arching. His arms are kind of moving in different directions. Dystonia can be with better cognition, it can be with worse cognition. It's not necessarily connected, and that is true with your premature kiddos. You tend to have similar patterns. Dystonia doesn't necessarily mean they have less cognition. Please never assume somebody that looks like this can't talk to you or understand what you're saying. They may understand better than somebody who walks in looking perfectly normal. So keep that in mind. Always give them the benefit of the doubt. So language is a big issue after stroke and brain injury, and you'll see a lot of overlaps here. Stroke, of course, tends to be focal unless you have multiple emboli going up into the brain or something like that, or over time, multiple strokes. Traumatic brain injuries, as opposed to that, tend to be pretty diffuse. So yes, you can have a contusion or a subdural that happens in one place, but we're talking about injuries that can very often have diffuse axonal injury where a lot of the axons are disrupted, particularly in the central areas. And so their aphasias can be a little more mixed and less specific than can patients with a stroke, but you'll see similar patterns. And so most of the time in the TBI, if they're going to have some aphasia or difficulty with speech, they're going to have a mixed pattern where they don't understand it all, or they may have a little delayed processing with understanding what you're saying, so they have a little receptive aphasia and sometimes a lot of expressive aphasia. So they just can't, they know what they want to say, but they can't get it out. And you can see where in a TBI they'd have a little bit of a mix of this, because if you've had a bad enough injury to have some language deficits, you're going to have some cognitive deficits as well, which is going to impact how you receive information in language. And remember, aphasia doesn't just affect speech, it affects writing as well. So it's not like they can write it down for you to understand it. The same part of the brain works with both. I had a little kiddo, she was 4, and she had a pretty significant expressive aphasia, and she does so well now. It's been 5 or 6 years, but she still has a little hesitation, a little bit of a lag with sentence structure and answering questions sometimes. Her receptive is very good, thankfully it recovered better. Paraphrastic errors are where you want to say one word, but it comes out not sounding like that word. And so it's not exactly word finding difficulty, because they may not recognize that this is a substitution, but they basically find a word to substitute for what they mean. Like it's a little compensation. It's very interesting. So phonemic paraphrastic errors are where you might say papple instead of apple, or you might say part of a word, and most of a word, but maybe add or subtract a letter. This does not count Walmarts or lymph nodes. Those, I think, just don't know medical terms, but it is something like that, where you're just substituting a little bit, but you can tell what word they want to use. Neologistic is where you sometimes can't tell what word they want to use, because so much of the word is replaced or inappropriate or incorrect that you can't tell what they're trying to say. So less than half of the word is replaced or inappropriate. Semantic paraphrastic errors are more like saying lion when you mean tiger, or they may say book instead of library. So it can be like a one-to-one substitution like that, or like a banana instead of an apple or something, but it can also be a part of a whole, like a finger of instead of saying hand. They also can perseverate, and this is probably the most common one I see, is perseveration, where they get an idea and they stick with it, or they have an answer to the question and they'll keep answering in that direction. I have a delightful child. She would make anybody have a good day, who comes in to see me, and she had a brain injury several years ago. She's now a teenager, and she is the happiest kid you'll ever meet. And if you ask her anything, she's like, yeah, okay, yeah, yes, yeah, to everything, even if it's not a yes or no answer. And so she perseverates quite a bit. Echolalia, I had a patient with that this week, an adorable little 3-year-old. It's when they repeat what you say. So this is not sibling saying, I don't know, what are you, or, are you talking to me, are you talking to me? That's an annoying childhood game, but they can't really help this. She was a premature birth. She had bilateral brain involvement pretty significantly, and she picks up what the adults are talking about around her, or whatever conversation's going on, and she'll pick up a name or a word or a phrase, and she'll repeat it. And so we were talking with the family, and I would say 90% of her conversation was just repeating phrases that we'd say. She would occasionally say something like, swim, I swim, and then she would kind of perseverate on the concept of she wanted to swim. Normal 2- and 3-year-olds can perseverate on ideas, but this was a little different. But she was delightful, but she had pretty significant echolalia. I see this not uncommonly. Dysarthria is where you kind of have slurring. It's just hard to understand. You can have dysarthria from a multitude of things. You can have it from a stroke, any kind of brainstem issue, posterior circulation stroke, ALS will cause dysarthria, myasthenia gravis can be dysarthric. So it's just kind of slurred words. It's just not fully articulated. And then lastly, word finding difficulty. This is common in all of us. If you catch me on a Thursday afternoon, you'll think I had a brain injury, but these patients have more severe and dense deficits than we all experience occasionally. And that's what's very frustrating. Behavior changes, of course. This was the whole concept behind the reports on Phineas Gage. He was injured on a railroad 100 years ago. If you can read what they said about him. He's very notable. He's all over the internet. And what they said was Gage was no longer Gage. Patients have frontal injuries that affect their executive functioning, and so they can become very, very impulsive and have really poor safety awareness and decision making on the one end. They can also be very aggressive and have just really quick to be angry and frustrated, and so that all goes into the same kind of disinhibition that can happen with frontal injury. They can also be skewed on the other side, where instead of acting too quickly and too suddenly and being too quick to get mad, they don't care. They're apathetic and they have really poor initiation. I've had 2 patients like this, and you'll say, okay, sweetie, can you lift your arms up for me? They're like, uh-huh. So it's not that they don't want to. She was very happy to be cooperative. She just couldn't initiate to do it, and she wouldn't initiate to talk or to do an activity. She was happy just kind of sitting there, which is off-putting and a little less common than impulsivity, but it can really go either way. They may have a change in preference for what they like. There's a book called Where's the Mango Princess? And the wife is talking of her husband who had a severe injury. She said he liked obscure Japanese cinema and was very highbrow, and he became very lowbrow and laughed at fart jokes, and she almost didn't know what to do with that. It was such a change in personality and preference. And you can think about, how would this affect these tasks that we are expected to do all the time, adult and some childhood? Like, how would a child that is suddenly impulsive and quick to anger now get along with their classmates? How would they respond in a classroom environment, group setting, or to their teacher? How could they keep up with assignments? What about if you're a parent and you have to instruct or be the responsible adult to a child, and now suddenly are angry and yelling, I think sometimes even abusive can come out of the parenting and the spousal relationships from a brain injury. With no pre-morbid tendency, they can become that disinhibited. How would it impact your financial decisions? You probably should think about educating the spouses about that. Now, we do that in rehab. Like, they probably shouldn't have access to the banking account and the savings account, because what if they just decide to go buy a boat? Or they just decide to go buy a car? I mean, they're an adult. They have an account. They have a license. I mean, nobody's going to stop them. They could gamble online. So they can have inappropriate decisions that can affect their ability to parent, to control household finances, to drive. Sometimes this impacts how they even plan and operate on a day-to-day schedule. Get up, get dressed, brush your teeth. How do you even manage those motor planning tasks that actually take quite a bit of executive function, even to the point of not keeping up with dressing and hygiene like they should? Are they remembering their deodorant? Do they take a shower every day? Etc. And of course, cognition is a huge part of a brain injury, especially executive function and attention. So executive function sometimes, I think, is difficult to explain, but this is a really good diagram. It's how to organize yourself and have daily tasks in an order of operations to plan and organize. So it's actually doing the action. It's remembering what you need to do in the order in which you need to do it. It's managing your emotions during the process. It's the appropriate amount of effort, right? You're not impulsive and you're not apathetic. Being able to focus on what you're doing and not get distracted and shifted into other tasks and leaving something undone. And it's actually to get up and get going. Yes, we all have trouble with that, but we're tired and busy. This is an ongoing issue with getting up and doing. It can also be overlaid with depression. Yes, of course, depression affects these things too. And mental health can affect these things too, and that can overlay some of their cognitive deficits, of course, especially if they have enough cognition to know they're not how they used to be. So that, of course, should be considered, but these can just purely be a result of a frontal lobe injury. So sometimes what I'll do if I'm trying to assess this is ask the patient, tell me how you make a peanut butter and jelly sandwich. Tell me what you do when you get up in the morning. From the time you wake up till you time to get in the car to go to work, what do you do? And sometimes they'll struggle. I've read a journal from a brain injury patient, and just about how she would get so distracted and half do things and make her bagel and forget to eat it, and not realize until she was hungry later that she didn't eat, or not realize that her hair was sopping wet and she was underdressed until she got outside and she got cold. So organization and even writing some of this down to follow a strategy can help these patients cope. Paying attention is a big part of remembering. If you're not attentive and you're not listening, how are you going to remember what people said? Or attending to where you parked your car, or attending to who you're with, etc. You have to remember these patients have some delayed processes. Give them a little more time. They may take a little longer to respond to you than you would expect, and so especially in the hospital. So I would repeat the same thing for at least a minute before moving on to another, because if you ask them to, let's say, give you a thumbs up, and then they don't do it, and so immediately you say, okay, well, wiggle your nose or close your eyes, they're not going to be able to keep up with that. They're going to get way confused, and you may not be able to access what they can do. All of this goes into memory. If you think about it, memory is very dependent on how many times you've thought about it, right? The more you do it, the more you go over it, the more it's over and over and over and over, it gets grooved and is really embedded in the brain. That's harder to damage and get to than a memory that just happened. So we talk to patients about what they remember before the accident. Do they remember what happened? Do they know why they're in the hospital or the rehab center? And then maybe what they had for breakfast. What day is it? Who is your nurse today? What's your therapist's name? Anything that tells you that they're grasping and holding on to some more short-term memory facts. And so there are other memory questions, of course, but some of those are very practical, and if you're dealing with someone who already has cognitive issues, simply asking what they've had to eat, which everybody should remember, or getting them to tie their shoes, or showing you how they brush their teeth, or, some of that can really get it down to a practical level. And if they can't do that, then you can really see. Obviously, this impacts learning. The younger you have a brain injury, the more this will then be impactful. Cranial nerve injuries, they're right there. They're on the base of the brain. Look at it. And many of the eye movement cranial nerves are right around where you can have uncal herniation or pressure. It's a pressure-sensitive area. So cranial nerve injuries are pretty common with TBIs. Cranial nerve 1 is the most common. It's the most vulnerable nerve because it sits right under the frontal lobe, right? And all these little bitty neurons come out from it in between the cribriform plate. So what happens if you shake that? Right? If you have really a distension, a traction injury where the head is going back and forth quickly, those little nerves and that very scratchy, rough surface and through that sieve really can get pulled and distracted faster than anyone. So a loss of smell or impacted smell is very common. Always be screened for, because that's going to affect their ability to have an appetite and take in nutrition, and that's going to impede their recovery. And so sometimes the first thing I'll screen for this, even in a concussion, is does food taste the same, or how their appetite is, or if they're eating new and different things, or if things taste the same. Like, what's your favorite thing to eat? Okay, let's say Kentucky Fried Chicken. If you go to Kentucky Fried Chicken and have a fried chicken, does it taste the same? And some people will say, it doesn't. I can't eat there anymore. It's just not my favorite anymore. It doesn't taste right. And so then you can follow up with more sensory testing. The eye movement ones, 2, 3, 4, and 5, to a certain extent, are also vulnerable. 2, 3, 4, and 6, I think, is what I meant to put there. They're vulnerable because of the location. In fact, 6 is the outside one of that group, and so AB adduction abnormalities are pretty common. With a traumatic brain injury, obviously, if you have facial fractures or any kind of laceration to the face, cranial nerve 7 can be involved. This is not usually so much the central injury as a peripheral injury. And I've had patients with bilateral trauma to the facial nerve, or at least unilateral one. This is not uncommon either. You can have vestibular issues. Vestibular issues are very common after even a concussion, where they have dizziness, vertigo. You can have benign paroxysmal vertigo, benign positional paroxysmal vertigo from the trauma to the inner ear. So this can also affect their balance, their gait, and where they are in space. They can get pretty confused, especially if the temporal lobe is also affected, where they're processing this information. You kind of skip down then to 12. Some of these are a little better protected. You can have a hypoglossal nerve injury, but I would say it's much more likely in a pica injury from a stroke. The other thing I'll say is cranial nerve 2. Your vision can be impacted, obviously, anywhere along that optic chain. So the optic nerve itself can be affected, and then any of the processing centers posterior to that. All right, so what are we looking at the hospital typically? Somebody's been injured, they're hypercoagulable, they're not moving, they have a risk of clot. So that has to be really, 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 really high up on your list of appropriately controlling. It can, of course, be difficult in a brain injury if there's extensive bleeding. But we have to be on top of it, because people will drop dead of PEs in rehab if we are not aggressive with this. It is a very common complication. Bowel bladder incontinence. So if you aren't aware that you have to go, or your body can't take you there in time, or you have delayed processing to be aware that full bladder means walking to the bathroom, all of that is impaired in a brain injury. And so what we usually do is have certain times of the day we take them to the bathroom in rehab. Obviously, in the acute hospital stay, they probably have a Foley in a diaper, but as we're trying to edge them toward home, that's a good way to keep them continent, because they can't control it typically. They just can't process what it takes to go through those executive functions. They can have hypovolemic pituitary axis issues. That can be low thyroid. It can be too much salt wasting. It can be too much water retention. It can be any kind of sodium channel abnormality, basically. They can be amenorrheic. They can have decreased testosterone. They can have increased calcium. So that's a different metabolic reason. But they can be thrown off from these things, and it can affect their fatigue, and it can affect their cognition. So it's important to keep that in mind and continue to screen. I would keep a really close eye, especially on sodium early in throughout the hospital stay. The risk of seizures is always there with any kind of brain injury. If it's a penetrating trauma, like a gunshot wound or a stab, or if there is a fracture, you have a higher risk of long-term seizures. We kind of give seizures in the first week a break. That can be from swelling and some of the acute events and medications and electrolyte abnormalities. But if a patient has seizures after that first week, they're more likely to have long-term seizure disorder. So what do? Well, we start with therapy. We do physical therapy to help with their walking and their balance and their strength. We do occupational therapy to help them relearn how to take care of themselves and get dressed and bathed and toilet, to do fine motor skills. And OT actually does visual perception, which is really critical to reading and learning, especially for children. And then speech therapy works on their swallow, because they can do dysphagia. I didn't say that. I missed it. But they obviously had difficulty with swallow early on. Language and cognition, and speech does all three. Neuropsychology and counseling follows up. It gives that good comprehensive cognitive assessment that can be good objective data for what kind of work they can do, or what they need to, what kind of support they need when they go back to school. Medications for the things we've mentioned: behavior, seizures, DVT prophylaxis, etc. They need management of those things. We can help them with some of those things. Timed voids we talked about, and we needed to think about and be aware of support in the community for them to go back to school, go back to work, and help them think about what may or may not be appropriate, or even if they can return to work, return to driving, etc. I'm afraid we do not have them in Mississippi, but there are long-term facilities, long-term rehabilitation places that teach life skills. These patients live in an apartment-like setting with an advisor or somebody that helps them go through day-to-day. So they help them go through simple grocery shopping. They then cook and clean for themselves and do laundry, and they have group activities like movies and so forth. So they socialize in a little bit, and they work on some work preparation skills. And sometimes that can take a few months, and sometimes they can take over a year. But they can get that next level of advanced life function and independence beyond what we tend to do in acute rehab, which is make sure they're safe to get around and take basic care of themselves. Texas and Dallas has 2 really good ones that we have for patients too. So this is a nice summary if you want to glance and just kind of get an overview of what these patients may be experiencing or dealing with, because TBI is a little tricky. It's hard to see. But there's so much to do for these patients, and we wouldn't want to miss one of these issues we could be helping them with. So, thanks guys. See you under concussions.